Good day, everybody. Dear colleagues, it's a pleasure for us to discuss with Shahrokh Shariat a very important issue, because we all know the approval of certain drugs in the metastatic setting of advanced urothelial cancer. But the reality is that these drugs are already in the pipeline of the locally advanced and the localized disease. And today we wanted to discuss this very important issue, which are the potential barriers to immune checkpoint inhibitor use in muscle-invasive bladder cancer. So Shahrokh, the floor is yours for 10-15 minutes, and then we'll have a short discussion around this topic. Thank you very much.
Thank you very much, Morgan. Thank you, the ESOU, for this great program and for this challenging presentation looking into the future. So what are the potential barriers? And I have to start with some of the disclosures. I work obviously with many of the companies on those drugs in different settings, and I will discuss them. If you look at it, the rationale for perioperative cystectomy therapy is that the deaths that occur are not local events. They are a result of metastatic disease. We need just to do better than radical cystectomy alone. The local interventions would not deal with these macrometastases. How can we deal with them? Well, multi-agent chemotherapy can cure some metastatic urothelial carcinoma. Specifically, patients, for example, with only lymph node disease have a over 16% 5-year survival. And the IOs can lead to sustained remissions in a metastatic setting, be it in a primary or in a secondary metastatic setting. So they're quite promising in some of the patients. It's a small fraction, but they're doing really well. I will a little bit focus on the neoadjuvant setting, because here there's a lot of data and a lot of concepts we can discuss, but I will also talk about the adjuvant setting. The neoadjuvant is also quite interesting because the pelvic blood supply is still intact, allowing drug access. So I believe that systemic therapy could eradicate macrometastatic disease, improve upon radical cystectomy or local therapy alone, and thereby improve cure. So the rationale is clear. As we heard from the previous lecture, all the guidelines support a neoadjuvant chemotherapy in this setting with a survival benefit of approximately 5 to 8% at 5 years. There's also the great concept that we need to move forward to in bladder cancer, similarly to other diseases, have a dynamic response mechanism, in vivo chemosensitivity. So you're giving the neoadjuvant therapy, you look at the radical cystectomy specimen, you see, was there a response, and then do some molecular analysis to see in those that there was no response, how can we salvage through targeted actionable alterations. We also heard from the lecture before that despite this strong evidence and strong recommendations from the guidelines, neoadjuvant chemotherapy is rarely used. Now, at university settings, you may get to 30%, 40% in best case scenarios, but in a community use, we're talking of a minute fraction of patients being offered neoadjuvant chemotherapy. So here comes the question, and I try to extrapolate from the lack of uptake of neoadjuvant chemotherapy to the future potential barriers of neoadjuvant IO or adjuvant IO therapy. So why is neoadjuvant chemotherapy been such a failure in uptake? One, the high rate of cisplatin ineligibility. Over approximately 50% of patients will not be able to get neoadjuvant chemotherapy with cisplatin as a combination chemotherapy. Number two, I think it's a very strong rejection by many patients refusing chemotherapy. The concept of chemotherapy, the side effect and toxicity of chemotherapy is not very liked by patients. We see it on an everyday clinical basis, and it's also enforced a lot, unfortunately, by physicians, this fear and this reluctance. We also had in the past, and still have in a community setting, a strong barrier called the lack of multidisciplinary approach. The fact that you're not sitting and talking and partnering with your medical oncologist and with other specialties will lead to a less common access to the neoadjuvant drugs. And certainly another thing that we hear commonly is the fear of losing the patient to the medical oncologist and never receiving the patient back for radical cystectomy is one of the fears of the urologists in general. There's also a fear of complications during the chemotherapy. The chemotherapy with cisplatin-based combination is certainly a toxic therapy that comes at a certain cost, but also there's a fear that this will render the radical cystectomy more complex, more difficult, and so on. We have heard from Virginia before in her talk that this is not the case. There's also a fear of delay of the surgery, and this we know from quite a lot of literature that the delay of surgery may lead to worse outcomes, and specifically non-responders for neoadjuvant chemotherapy, that could be the case. I personally feel that chemotherapy is an effective drug, so it's not like you're delaying effective therapy, you're just delaying surgery, but you're giving already effective therapy now. Now, the non-responders will remain a problem in that setting. And the last one is the reason the outcomes, perceived outcomes of the clinical trials seem better than that in the community is because there's a high difference in quality in the medical oncologist in the community. What I want to say, I want to point out this study that is quite a nice one, that if you get suboptimal neoadjuvant chemotherapy, which is commonly given, and we have seen it even in clinical trial setting, in the metastatic setting, this will not lead to the benefit we are expecting. And if that is seen, that makes the urologist even more reluctant to send the patients. So these are the barriers, perceived barriers to neoadjuvant chemotherapy. Now, a new age has started with the IOs in a metastatic second line and first line setting, and now moving forward to the neoadjuvant and adjuvant setting. Already in other disease entities, the neoadjuvant setting has become quite attractive and widely used, with results of clinical trials being promising. There is a strong body of work suggesting that the neoadjuvant setting is ideal for IO therapy, even better than the adjuvant setting, because here you have a strong increase of CD8 positive T cells in the neoadjuvant setting, resulting being an indicator for long-term survival. So the neoadjuvant, where you have a potential encounter of the tumor and the immune cells, and your T cells will result in a better outcomes than in an adjuvant setting where you don't have any tumor present. This is the concept for neoadjuvant. Therefore, I will spend a little bit more time on the neoadjuvant setting. Also, the data are there more right. These are the current trials. What can we learn from them? The Pure 01, the Abacus, the Nabucco, and the Pandora have not been published yet. And there's a checkpoint inhibitor with chemotherapy that I will also talk about. So I'm coming now to the potential barriers of the underuse of neoadjuvant IO, right? And I'm trying to extrapolate from the challenges we had in the neoadjuvant chemotherapy. The first question, will there be any IO ineligibility? So as we have with cisplatin, I would say this is very rarely the case. Certainly could be, and in a neoadjuvant and adjuvant setting, we're gonna be a little bit more careful than in a metastatic setting where you will have no choice, but I think that's a rare case. So here we have a huge population that could potentially be your target population. Number two, the patient refuses IO. Will that be the case? I think the reluctance for chemotherapy is quite big, with a lot of negative stigma on chemotherapy. That is not the case with immunotherapies. I think the patients as well as the physicians are much less likely to reject IOs in this setting. What about the multidisciplinary approach? So historically, the multidisciplinary approach has been a hindrance to chemotherapy. Today, over the last 5 to 10 years, we've improved a lot. We're working as teams. We have realized that best delivery of care in any disease entity will be through partnership, and that is also a step forward for the chemo, but also at IO. What about the fear of losing the patient? Well, I think today with the checkpoint inhibition and with the guidelines and so on, we have much more evidence-based medicine. So today, if a urologist is not referring, at least for a discussion, to the medical oncologist, or like in Germany and Austria themselves, we deliver our own systemic therapy. If that is not happening, the patient knows it through websites and so on, and is inadequately treated and will complain about it. So that is gonna also go away by a large part. What about the quality difference in medical oncologists? Well, I think chemotherapy is given many different ways, be it in different cycles, in different regimens, in kind of unregulated across trials and across centers. That is very different thanks to the new clinical trials and the effort by the industry with the IOs. You have a much stronger education and standardization of care. You know how many cycles, you know how to give it, and that's going to be a lot more standardized. So I think the quality differences will decrease quite a lot. There's two things that remain: the delay of the surgery and the complications during and after, during the IO and after the during the cystectomy. I will show you some data to convince you that this is not the case really. The PURE-01 pembrolizumab trial, 3 cycles of pembrolizumab were given prior to radical cystectomies. All patients that were included got their surgery, 96% within 12 weeks, so really within a timely fashion. Almost everybody received after 3 cycles. And if you look at the complications, approximately 30% had post-surgery AEs, and only 6% had grade 3-4. What about the efficacy? 42% pathologic complete response, which is highly promising, and in the PD-L1, even higher. This group of Alberto Briganti and Necchi from this trial, the PURE-01, even went into a very rigorous prospective surgical outcomes assessment. And what I found out that the result, this is not a randomized trial, but the result of this study that was well documented prospectively are not much different from a typical radical cystectomy cohort. The Abacus trial was the second one published by Tom Powell with atezolizumab. Here you got even only 2 cycles of the IO, which is quite a short strategy, but very efficient. Here, 8% of patients did not undergo surgery, which is a little bit more worrying. You had 2 perioperative deaths. This seems quite a lot to me, but this could be a statistical fluke in this short a small cohort. The grade 3-4 was around 11%, which is in the rate you would sort of expect depending on your case mix. Here, the pathological complete response was 31%, highly promising again. So if you compare them, the neoadjuvant IOs to the neoadjuvant chemotherapy in efficacy, so it's something that is very important for the patient and the clinician, we are doing quite similar, right? What about the side effects? The side effects are much less on the IOs compared to the chemotherapy, and that is what I told you before. The patient and the physician will certainly not put that as a barrier to the IOs and will be mostly endorsing the IOs if it's given a chance. There is also a new trial, the Nabucco, not published yet. Here, there's a combination of 2 IOs with a mixed regimen. And here, the problem with that is that if you increase the IO combination, you have more toxicity, approximately 40% grade 3-4 toxicity with 8% colitis. Despite the good results and efficacy, it's not good. It seems too much for that setting to be acceptable to the clinician or urologist in that setting, and also medical oncologist. So the combination therapy with chemotherapy is certainly one thing that we expect to get more mileage out of it, with activation, infiltration, faster response, more frequent responses, and more durable responses. Here, there's been one study that has been preliminary data with a combination. Here, there seems to none of the patients failed to undergo surgery, but there was one post-operative surgical death, and the grade 3-4 was sort of in an acceptable rate, but super interesting pathological complete responses, or if you want, responses in general. So I think quite interesting in that setting too. So efficacy is good, side effect is acceptable, surgery does not become more complicated as you go with a single agent IO. If you're going to get combination agent IO or combination with chemotherapy, the data needs to mature a little bit more. One of the questions is going to be, in general, how we're going to think about neoadjuvant systemic therapy, and are we going to take this opportunity of the IOs to a little bit refine our access to neoadjuvant? Will we refine our clinical staging to identify the high-risk individuals, to minimize morbidity and cost by avoiding ineffective neoadjuvant systemic therapy? And will be how we're going to identify the responders, and so that we can improve on those response rates. So this is going to be one of the challenges, and for that we have to rethink our definition of stage, and not only take the CT scan, but take a lot of factors. Certainly the tumor biology with biomarkers, LVI, molecular genetic features will play a major role. For us already today, for the neoadjuvant chemotherapy, we identify the low-risk patients and the high-risk patients. The low-risk patients, we believe that they have a high chance of getting cured with radical cystectomy alone. And we discuss with them the neoadjuvant chemotherapy, but we certainly are not going to push strongly for that. These are the patients that are clinical T2, have pure urothelial carcinoma, no LVI, no hydronephrosis. Those that have any of those features, we consider high risk. In those patients, we know the cure rates with radical cystectomy is going to be less likely. In those patients, we're going to push quite strongly for neoadjuvant chemotherapy. I think the same thing is going to happen with an IO therapy, with some sort of a risk stratification to get the maximum mileage out of those systemic therapies. But the future certainly is going to be looking at molecular defects. This is going to be very important in the future. For example, DDR, genomic alterations, will play a role in identifying those patients most likely to respond to neoadjuvant chemotherapy. Within the PURE-01, the next generation sequencing has identified predictive biomarkers, also for combination therapy, for example. But the biggest promise is certainly molecular subtyping. This molecular subtyping will allow us to identify which tumors are going to be most likely to respond to specific targeted therapies. And certainly now already we can identify signatures that make you more likely to respond to neoadjuvant chemotherapy, or as you see here, more likely to respond to checkpoint inhibition. That in a muscle-invasive scenario based on the TCGA data and other data that are available. So I foretell that in the future, probably we're going to have signatures, as you can see in this slide, that will identify the likelihood of responding to cisplatin-based chemotherapy, and a signature that will tell you the likelihood of responding to IO therapy. And based on those signatures plus clinical factors, we will then choose the ideal therapy. I could imagine a stepwise approach. First, checking PD-L1 TMB, and then second, looking if you're going to be cisplatin eligible, and already there have your targeted therapies, and for the cisplatin ineligible, another therapy. So here we can, based on those three factors, already today make a selection for each individual patient. I'm not going to spend too much time on the adjuvant setting. Certainly the adjuvant setting is also promising because you know the pathology, you have no delay in definitive local therapy, and so on. The data for the adjuvant chemotherapy has been very short and disappointing, but there's been adjuvant checkpoint inhibition. There's been one trial that has early results being a little bit disappointing, but one trial that has met its primary endpoint of disease-free survival, the CheckMate 274, has been already reporting, but we're going to get more data maturing over time, and we're going to look if this is going to translate in overall survival benefit. So in conclusion, I think that immuno-oncology has changed our perception of urothelial carcinoma, not only in a metastatic disease where uniformly lethal disease has finally received some hope, but even in a locally advanced and localized disease. But we're still waiting for longer term outcomes to see those results, but highly promising with a frame shift in our mentality. I think one of the biggest strengths will be lowering the barriers to uptake in the perioperative setting of systemic therapy with the IOs will be the very favorable adverse event profile. Multiple open questions remain. How can we improve the response rate? How can we overcome the immune escape? How we select patients? Should we not take now the opportunity to have some sort of precision medicine approach and a personalized approach with the IOs in this setting? with biomarkers. We need to do that. And I certainly think that the future will belong to some sort of combination therapies, IO or chemo IO or other ways. And it certainly will shift a little bit away from radical cystectomy alone. I could foretell or foresee that chemoradiation, for example, with an IO could result in tremendous response rate. Data is still missing, but just my guess here. And then the last question that will come, what if the IOs have been used in earlier disease stage? We have seen in BCG unresponsive and earlier stage IOs are being tested. How will that change our armamentarium in the perioperative setting around radical cystectomy? That will be also something we need to face and think about early and already now. Thank you very much for your attention. And I'm very happy to discuss this talk and other concepts with you in the next few minutes.
Congratulations, Shahrokh, for this excellent presentation. We gave not only an overview, but several thoughts about what could become the future of urology. And I think it's very important that the urologists consider themselves not only as surgeons, but as physicians taking care of the disease itself, because we are not even sure that in a few years we'll be moving forward in the field of taking out some bladder, and maybe the medical treatment will become enough. We don't know. We are working on it, and we need to be an active part of that. That's very important to see from your lecture that one size fits all is not the rule anymore. And there are several options potentially on the table now. And I think that many people who are reluctant to deliver the chemotherapy were arguing by the fact that they were non-responder. And we can believe from your presentation that a proportion of the patient will be responding maybe to a certain type of drug, and then a subgroup will respond to chemotherapy, and another group will move straight forward to surgery. So maybe Virginia, one point that we are all connected after the presentation of Shahrokh. He made a very important point, which is, do you believe that from the perspective of the physician and from the perspective of the patient, immunotherapy will be much more accepted than what the chemotherapy be? Because the general media, the mass media, is speaking a lot about all these new drugs, which makes it a bit, I would say, popular in the population. So what do you think?
Well, I really think that this will be the future, because right now we have a treatment that's chemotherapy that we know is effective, but the effect is modest, but the toxicity is considerable. So we now have drugs that seems to be at least as effective as chemotherapy, but the profile of toxicity is really, I think immunotherapy do outperform chemotherapy in toxicity profile. So that will be really important when we make our decisions.
Benjamin, you were for a lot of time involved in many, networking for the young generation of urologists, organizing new training and new activities for the young generation. What is your vision? How do you embark the young generation of urologists in delivering this drug? Do you feel they will be comfortable, they will be interested in, or it will be only a few proportion of, I would say, academic urologists? What is your feeling? Because I have the feeling that the urologists are much more attracted by a robotic live surgery than to understand the higher prescription. So Benjamin, I will be happy to know what is your vision, so how to train the urologists with all these new options.
I would thank you, Morgan, for the question. I think from a European point of view, we have lots of discrepancies on the way to learn and to be teach on the use of this new systemic treatments. I think we are more concerned than our senior about the importance of this neoadjuvant setting and the precision medicine, the use of NGS, or the management of the toxicity from this drugs. So I think we just need to be more focused on the management of these drugs for the young generations, because they are easier to manage and I think there is really room for the urologist to perform these treatments in a global understanding of the disease. And I would only repeat a sentence from one of my mentors who says that you don't marry with a technique, but you marry with a disease. And I think actually we need to focus our I would say teaching on this global understanding.
One last point, I think, before we close this part is coming back to Shahrokh. You mentioned that it was really important to have a broad vision of what's going on in the field of muscle-invasive bladder cancer, but will IO open the path for trimodal therapy? And I think you made the point in your last slide, but what is your personal opinion on that, Shahrokh?
At the moment, I think trimodal therapy is a very rarely and should be a rarely used therapeutic strategy. It is certainly not yielding the success rates, and it certainly has a lot of limitations in those patients that we hope to deliver it adequately. It forecloses a lot of opportunities in those patients who could get it. I'm talking about a neobladder, nerve sparing, and so on. So the selection is not yet clear. And so I think at this moment, I'm not a big fan of it personally. Select cases with the shared decision-making with the patient, yes, we can go that route. I think the promise that IO brings in the setting is not only in the metastatic setting, in a neoadjuvant and perioperative setting, it will shift the way we think about this disease. And probably some form of abscopal effect we expect and hope to receive in combination with the radiation and with the chemoradiation therapy. And there's a protocol, there's 2 protocols already in clinical trials. And maybe we will see here a high response rate, less failure, less need for secondary salvage cystectomies with the detrimental effect. And I think that is going to be one of the promises that IO will bring to us, and thereby also, we all love radical cystectomy. A little bit allow us to not deliver that surgery in that high frequency with all its morbidity.
And maybe one last point before we close the discussion is the fact that the IO is actually considered to be a systemic drug. But we all know that we have in the pipelines even some drugs who are already available systemically, who are in phase 1 or phase 2 trial already in the US, already delivered intravesically. And I think it makes sense for the urologist not only to consider the potential efficiency of the disease, but to preserve the technical aspect of the delivering of the drug, because we all know that there are FGFR drugs developed by a certain company which can be also delivered locally. And do you believe that if you want to control the micrometastatic disease and the endocavitary disease, that it makes sense maybe to not only deliver it within the bladder, but in a systemic manner, in a local manner? And what do you see on that particular point?
I'm not sure. I will answer if you want, and my colleagues as well. So I think it's certainly in the earlier the disease, the more you want to go intravesical, the more likely it's going to be a localized disease. So in the BCG unresponsive or the high risk non-muscle invasive, I think a local delivery will be a game-changing application methodology with less side effects, probably, hopefully, and with the equal efficacy, which remains to be seen. In the patients that we are talking about perioperative disease, we certainly, or periradical cystectomy disease, in those patients, what we're trying to deal with is with the macrometastasis. So I think the systemic delivery will be still the primary target. And the best way of yielding the best results at this moment, I see certainly in identifying the proper amount of cycles, and the question how we can combine it with other therapies to get more efficacy out of it, so we can avoid the radical cystectomy probably in some of these patients. But the second one is also in what Benjamin has talked about education to the urologist and to the whole medical community in identifying early adverse events, dealing with them efficiently, not foregoing a whole therapeutic strategy just because we're trying to have a fear or mismanaging the adverse events. So I think education will be there the the key to success, and systemic therapy will be still necessary if our enemy is going to be the macrometastatic disease.
Okay, I think we need to close this session, and we'll see you in a few minutes for the third part of the ESOU Online model. Thank you.